and thought it would be appropriate to start with a case presentation. And in this particular instance, this is a video clip of a 61-year-old male with a BMI of 28. He's hypertensive with diabetes. He's at 6 months after an anterior wall MI during which he had an LAD stent placed. He collapses at the airport while arguing with an airline representative. Probably one of the most stressful situations we find ourselves in these days. Now, based on video surveillance, we know that CPR was initiated and 911 call was made in about 54 seconds. Notice behind the counter the typically helpful airline representative observing everything that's going on as bystanders perform CPR. In this particular instance, an AED arrives in 2 minutes and 10 seconds, and the patient was indeed shocked at 3 minutes and 43 seconds back into normal sinus rhythm. He subsequently was transported to a local hospital, stabilized, went through hypothermia. His LAD was patent at angiography. He was neurologically intact and is treated appropriately medically, and 9 days afterwards had an implantable defibrillator placed and has gone on an exercise and weight reduction. And this really represents the prototypical patient with sudden cardiac death who survives based on the chain of survival. Early initiation of 911, started by CPR, external defibrillation, and then advanced cardiac life support. And we've come a long way. In many metropolitan areas now, survival rates neurologically intact are approaching 30 and 40%. But it still represents the most common cause of death in the United States, in virtually every industrialized country. Sudden death or instantaneous death, unwitnessed death, are occurring within 1 hour of the onset of symptoms. And in the vast majority of people, this is due to underlying coronary artery disease. So that will be the focus, really, of the patient population we're talking about. Now, in the United States, there are variable estimates of the number of sudden cardiac deaths. It's probably in the range of about 200,000 each year. Some estimates actually have it double that. In almost all these settings, it is the result of progression of coronary artery disease. Now, we can look at various groups of individuals here, as shown. If we focus here in the lower left, we look at patients with previous MI, low ejection fractions, and ventricular tachycardia, and you can see their annual risk of sudden cardiac death might be as high as some 30%. And in that regard, there have been trials like the MADE-1, the MUST trial, who have looked at the implantable defibrillator in those patients. But the dilemma comes in the following way. If we look at the top of the left-hand column, this is the general population of patients. Now, their risk of sudden cardiac death is very, very low, but there's several 100 million of those people who are at risk. So the vast majority of sudden cardiac deaths, as you can see in the upper right, are coming from low-risk groups who have not been identified in trials that have looked at either home defibrillator or implantable defibrillator. And this, of course, is the great dilemma of prediction and prevention of sudden cardiac death. So it's about 1 in 1,000 a year in the general population, but most of the sudden cardiac deaths occur in that group. Now, the substrate is typically an anatomic substrate modified by transient initiating factors. Many times it is physiologic stress, either mental stress, as was the case in the case that I presented, or physical exertion, emotional or physical stress, with the triple hit model causing arrhythmias. And there are multiple different kinds of arrhythmias, and interestingly, there's EMD, asystole, ventricular tachycardia, ventricular fibrillation. The triggers of these things are multiple and complex and poorly understood. They're dynamic, they are unpredictable in the individual patient, and that creates a huge problem relative to predicting and preventing sudden cardiac death. Now, in these patient populations in whom the trigger and the substrate is there, they can have any number of mechanisms, including monomorphic ventricular tachycardia, polymorphic ventricular tachycardia, ventricular fibrillation, or even bradyarrhythmias as the mechanism. If we look at the relative frequency of these events, the frequency of all cardiac arrest is going down in the United States, largely because the frequency of MIs is going down, and in particular the patients who have had marked impairment of left ventricular function are getting the benefit of early intervention, reperfusion, ACE inhibitors, beta blockers, aspirin, and if they persist some 40 days after the MI, they're getting implantable defibrillator. Now, interestingly, the frequency of asystole has stayed the same. PEA has stayed the same, probably representing very late manifestations of the underlying coronary artery disease, with survival rates going down about 10% per minute. So when you find a person in asystole or PEA, it usually indicates they've been through a prior period of sustained ventricular tachycardia or ventricular fibrillation. Now, there's a very clear decline in the frequency of ventricular fibrillation as the initial rhythm in out-of-hospital cardiac arrest. Mechanisms are unknown, but it's very likely related to intervention with optimal medical therapy, including statins, and revascularization, particularly stents, which are not having the progression in stenosis that we previously used to see. So this represents, again, the great dilemma that we have. If we look at the patient population on your far left who have markers of risk, a prior myocardial infarction, impaired left ventricular function, they represent only 5 to 10% of the entire population. By contrast, if you look at the people on the far right, these are individuals who might have known coronary artery disease, but have very low risk of sudden cardiac death. But because the numbers of patients are so much greater, most of the deaths actually occur in these low-risk patient populations who've never been studied in terms of prevention of sudden cardiac death. So in that respect, because we can't prevent sudden cardiac death on a primary basis, these secondary mechanisms such as AEDs, community-based CPR programs, and implantable cardioverter defibrillators for sudden cardiac death work very well. So sudden death accounts for about half the total mortality in the first year after an MI, and then it drops off quickly. So this time dependence is really very critical, because if we're going to intervene, we need to intervene early in the post-MI period. And sudden death is, risk stratification is dependent on techniques that are practical, typically non-invasive, sensitive, and have a high predictive accuracy for sudden death. And the fact is, they need to be cost-effective as well. And we are falling far short of enriching the patient population, for example, with implantable defibrillators, so that we have a very high ratio of patients at risk for sudden death who actually receive therapy versus the denominator of patients who've had a prior myocardial infarction. So we use the left ventricular ejection fraction. It's the best marker we have. It's stood up now for over 3 decades, going back to the Mr. Fit trials. The risk of sudden cardiac death increasingly progresses as the LVEF decreases, a continuous variable. Typically, we use 40%, and in many of the trials, it's been 35% to distinguish low from moderate or high-risk individuals, but it lacks specificity. The problem is that across a broad range of ejection fractions from 40% down all the way to 10%, the risk of sudden death to total mortality stays constant. So we need better risk stratifiers. And we've looked at a number of non-invasive and invasive risk stratifiers. They've all fallen very short, unfortunately, of giving us something that can give us a very high predictive value. In an ideal world, we would only put defibrillators in patients who we know were destined to have a ventricular arrhythmia death. Well, as it turns out, many of the deaths immediately post-MI are recurrent ischemic events, myocardial rupture, VSDs, papillary muscle rupture. They're mechanical events. And this is reflected, I think, in the fact that in this first 6-month period, you can see there's about a 20, and in some cases 30% incidence of sudden death, which presumptively had been arrhythmic, but increasingly we're finding, particularly for some of the trials of review, these are actually mechanical complications of the event themselves. So let me actually give you a case to represent the dilemma that we have. And this is a colleague who I trained with, who at age 58, several years ago, had an anterior wall MI, cardiogenic shock, balloon pump, 5 days of pressors. He had a PTCA of the LAD with VF at 16 hours after the onset of chest pain. He basically sat at home and denied he was having an MI and had VF in the hospital, fortunately. His LVEF was 20%. He had anterior wall hypokinesis. He really had class 2 to class 3 heart failure with a blood pressure of 90, barely tolerating low-dose ACE inhibitors, beta blockers, Plavix, and he was ready for discharge, at which point he called me and said they won't put a defibrillator in me. And I said, well, that's because it really hasn't been shown to have any benefit. So we couldn't put a defibrillator in. Family treatment with CPR and AED is something that has not been shown to work in the HAT trial, a prospective randomized trial. LifeVest has not been shown in prospective trials. So we discussed basically no additional therapy versus LifeVest. At the time, the LifeVests were just coming into be, and I said, well, there's very little risk with the LifeVest. It's non-invasive. We don't know, but the cost is low, so it's worth taking it. So this patient represents really the dilemma that we have. We knew he was at high risk based on ejection fraction, but we had no modification of current practices or interventions that would unequivocally prolong his life. So we'd looked at antiarrhythmic drugs in a number of trials through the 1980s and early 1990s, and noticed that many of these trials actually showed harm, with only the beta blockers showing benefit, and some of them having a neutral effect, specifically sotalol and amiodarone. But based on the failure of these drugs, we went on to try implantable defibrillators in immediate post-infarct patients. Shown here is the Dynamite trial, in which prophylactic ICDs were put in patients like the patient I presented, extremely high risk, prior to hospital discharge. And the ICD was associated with a decrease in death due to arrhythmias, but this was offset by an increase in the rate of death from non-arrhythmic causes. So if you prevent sudden death from arrhythmias with the defibrillator, these patients are at risk for progression of heart failure, myocardial rupture, recurrent infarction as well. So a completely neutral effect. But based on this, another group was studied in the IRIS trial. This is the cumulative risk of death in a very similar trial of patients immediately post-infarct who we know are at high risk, 20 and in some instances 30% risk of sudden death in the first 6 months. And guess what? No benefit from the implantable defibrillator. So based on this, the implantable defibrillator could not be put into this patient. What about the home external defibrillator? Well, this has been tried in a prospective randomized trial published in the New England Journal of Medicine. No improvement in outcomes in those treated with the home external defibrillator and CPR treatment. So 6 days post-discharge, with the life vest on in the middle of the night, this patient had ventricular fibrillation. He got shocked out of it, and he'd had ICD placed, progressive heart failure, and he actually went on to get a heart transplant about 9 months after his MI, and is back at work taking a little bit better care of himself right now. So there have been no prospective randomized trials that have shown that the life vest prolongs life in this patient population. And in fact, when he had his ventricular fibrillation, got taken to the hospital, balloon pump, LVAD, and heart transplant. He had a ventricle that was destined to die. A defibrillator was not going to make a difference. And fortunately, we were able to get him an accelerated heart transplant. So if we look at ICD trials for primary prevention of sudden cardiac death, you can see the Dynamite and IRIS trials in white, no benefit. Other trials, such as the Made It 1 and 2, SCUD-HEFT, in primary prevention patients, those with prior myocardial infarction and impaired left ventricular function, or in some instances, such as the Made It 2 and the SCUD-HEFT trial, those with dilated non-ischemic cardiomyopathies, there's a clear survival benefit with the defibrillator. And for secondary prevention with AVID, CASH, and SIDS, there's a clear survival benefit as well. So we do know that we can prevent sudden death in selected patient populations, and importantly, the registries that the ACC have set up have shown unequivocally that the patient selection and clinical outcomes in the real world of clinical medicine in which we practice, being mindful that it's mandated that we put every patient with Medicare and Medicaid into this database. There are now over 900,000 patients in it. The outcomes are identical to those seen in the trials. So it's an example of really how a database can make sure that the outcomes are similar to the clinical trials. So we've developed guidelines based on this that have been updated recently relative to CRT. We've looked at prospective trials of automatic external defibrillators, and what you can see is that these values have unequivocally shown benefits with public locations of external defibrillators. The dilemma is that about 70% of all cardiac arrests occur at home, with the majority of them unwitnessed during the night. So in public environments, the home automatic defibrillator, the defibrillator works, but at the home, it hasn't been shown to have any benefit. So evidence-based medicine demonstrates a decrease to definitive therapy with AED use. The results improve survival. The benefits are mainly in non-residential sections, public locations, health clubs, airports, casinos, hotels. And for survivors of anterior wall myocardial infarction, like the physician I presented who were not candidates for implantation defibrillator, access to a home AED does not improve survival, but the LifeVest, as an anecdote, in this patient did. So in the United States, we've actually worked through a number of issues, not just the clinical and the scientific ones, but also the legal ones. And we've taken a role in basically pointing out to physicians and to other organizations that the real risk comes from not having an automatic external defibrillator. As a matter of good public policy, anyone who owns a defibrillator, anyone who uses a defibrillator, has broad-based immunity at both the federal and the state level, thereby encouraging defibrillator use. And as a matter of prudent public protection, if you don't have a defibrillator, you're actually at risk if there's an adverse outcome as well. So this kind of summarizes, once again, the dilemma that we have. The chart is flipped now. If you look at the number of people on the lower right in the general population at risk for sudden cardiac death, and the incidence being low, about 1 in 1,000, you can see that most of the sudden cardiac deaths actually come in a patient population in whom we don't have any good therapies. So for high-risk post-MI patients or post-cardiac arrest patients, we can do optimal medical therapy and we can do ICDs, but 40 days after the infarct. For these low-risk patients, the treatment is primary prevention of coronary disease, which we've talked quite about with lifestyle and primary prevention measures that reduces the risk of either a triggering event such as a plaque rupture or the development of coronary disease itself. So I wanted to really emphasize the primary prevention, and this was the thrust of an article I published in Circulation a couple years ago. So the best treatment to prevent sudden cardiac death is primary prevention, primordial prevention, not developing any risk factors for coronary disease. Primary prevention and secondary prevention of sudden cardiac arrest with implantable defibrillators is appropriate. Use of beta blockers, ACE inhibitors, statins is appropriate. In the selected patient populations who match those in the trials, and implantable defibrillators are reasonable, as are community-based access to defibrillation programs, which have been shown to improve survival in locations outside of the home. And then, importantly, this advanced cardiac life support, these regionalized systems of post-resuscitation hospital care have resulted in a dramatic improvement in neurologic outcomes with cryopreservation of the brain and hypothermia protocols now. Over 70% of patients that come to the hospital are leaving the hospital neurologically intact. It used to be that it was only 30% of patients, but the cryopreservation of the brain definitely helps in this regard. So with that, I'll conclude and be very glad to defer any questions or comments until the final moderated discussion section. Thank you very much.